Hey, FRT community, we've got finals coming up this week, and this is day 2 of me answering questions, preparing people for finals week. I've got 3 subjects here I'm going to talk about. And this question comes from Shebra Nix, and she wants to talk about the laws of ventilation and the laws of diffusion. And then I'm going to give you a little bonus material talking about the basic principles or laws of mechanical ventilation, just for any of you second year students who may be heading into finals and unsure about mechanical ventilation. Okay, so when we talk about laws of ventilation, what we're talking about is Boyles Law. So this is Boyles Law, and what Boyles Law states is that in a given container, pressure is inversely proportional to volume. Okay, so in a given container, if the pressure rises, then the volume decreases. In that same container, if pressure decreases, then volume increases. Okay, so that's the first thing you need to understand here when we're talking about ventilation. Now, what you have to do is you have to put your mindset into thinking that when we say a container, we're talking about our lungs. And this is for spontaneous ventilation. When we talk about spontaneous ventilation, we have lungs, we have diaphragm, and we have cavity around our lungs. Okay? Now, what Boyles Law is saying here is that when the phrenic nerve excites the diaphragm to contract, then the diaphragm goes down. As the diaphragm goes down, you get a decrease in pressure. Now go back to Boyles Law. If pressure decreases, then what's going to happen to volume? It's going to go up. And this is what draws volume into the lungs. The lungs expand, and we call this a tidal volume. This is one breath. Diaphragm drops because of the lungs' natural state to want to collapse, and because of the ribs and the thoracic cavity's natural tendency to want to expand. You have something that wants to expand in conjunction with something that wants to collapse, and this creates a pulling towards each other. So you have a slightly negative pressure in the pleural space. So if your alveolar pressure at rest is 760, your resting pleural pressure is 756, slightly more negative. This is what keeps the alveoli open. Now when the diaphragm drops, all of this intrathoracic pressure becomes more negative. Pressure decreases. And as a result, volume increases. Now, that's during inhalation. Now, let's think about this. Boyles Law says that if pressure decreases, then volume goes up. And we just proved that. That's true. You take a breath. I took a big tidal volume. My diaphragm dropped. It created negative pressure, and volume inversely went up. Air was drawn into my lungs. That's the cavity. Now, at the end of inspiration, the diaphragm comes back up. As the diaphragm comes back up, inside of this cavity, pressure now increases. And as pressure increases, volume goes down, and that's how we exhale. Remember, inhalation is active, exhalation is passive in the normal, healthy, spontaneous breathing individual. Okay, so remember that. Talking ventilation, we're talking Boyles Law. As pressure decreases, volume goes up. As pressure increases, volume goes down. That's what creates inhalation and exhalation that we don't even think about, but that's the mechanism at play. Okay? Now, when we take this, now understand that we're talking about, when we talk about Boyles Law, we're just talking about ventilation. So Boyles Law equals ventilation. What's the definition of ventilation? It doesn't matter if you're talking about the respiratory system in a patient or in a person, or if you're talking about ventilation for your house or your apartment. The movement of air, the movement of gas is ventilation. You take it from one area, you move it to another, and then move it to another, and that's the movement of air. And that's what ventilation is. Ventilation says nothing about diffusion. Okay? So when we talk about this air that comes in, the diaphragm drops, pressure becomes more negative, and volume increases. That's just the simple movement of the air coming into our lungs. And then when the diaphragm comes up, pressure increases and volume decreases and air comes out. That's the movement of air, and that's Boyles Law, and that's in terms of ventilation. That does not refer to diffusion, okay? So when we talk about diffusion, we're talking about Fick's Law, okay? So when you remember Fick's Law, you remember there's three things that come into play, and Fick's Law is in reference to the movement of gases across a permeable membrane, such as the alveoli and the pulmonary capillaries. Both of those are permeable membranes, which means gas and fluid can move across those membranes. So moving of air is Boyles, diffusion of gases is Fick's Law. Okay? Now, Fick said that there was three things that would affect diffusion of gases. Okay, and here's what he said. Number one, he said the partial pressure. He also said that surface area. Surface area will also affect diffusion. And then he finally said that thickness will affect diffusion, stating the thickness of that permeable membrane. Okay, so let's break these down and let's just talk about these real quick. If you increase the amount of FiO2 being inhaled, then you increase the partial pressure of alveolar oxygen. So you have an increase in your P, big A, O2. Alveolar partial pressure of oxygen. If that goes up, then you will have more diffusion of oxygen across the AC membrane thickness. Across the AC membrane. Alveolar capillary membrane. When that happens, you'll result in more gas diffused, more oxygen diffused from the alveoli into the arterial blood. And that's true. We're talking normal, healthy individuals, okay? The second thing he states is surface area. So now surface area is if you increase the amount of surface area of this permeable membrane, then more gas or fluid will be allowed to pass across that membrane. So if you increase surface area of the alveoli, then it results in a greater level of gas exchange. What are we talking about when we say surface area and increasing it? We're talking about the addition of PEEP or CPAP. When you apply PEEP or CPAP and you get better oxygenation results, the reason for that is because of this increasing in surface area, which results in a greater level of diffusion across the AC membrane. Okay? I've said it multiple times. When I say AC membrane, I'm saying alveolar capillary membrane. That might be a test question on one of your finals. What is the AC membrane? It's not air conditioner. It's alveolar capillary membrane. This is the spot to where the alveoli meets the capillaries, and that membrane between the two is permeable. If you increase the surface area of the alveoli, you will increase diffusion of oxygen across the alveoli into the capillaries. And then the last thing is the thickness of that membrane. Now, when you talk about thickness, you have to understand that if thickness of that membrane goes up, then diffusion goes down. This is the oddball in this. Think about it. If partial pressure goes up, diffusion goes up. If surface area goes up, diffusion goes up. If thickness goes up, diffusion goes down. This would be a patient who would present with a disease process such as pneumonia. You have this consolidated area, these consolidated alveoli. And you can still provide PEEP, and you can still put more FiO2 in. But because of that extra consolidated mucus or consolidation that's in the fluid that's inside the alveoli, the capillary is here, the alveoli is here, but because this alveoli is now consolidated, look at the thickness that you have to go through to get gas from here into the capillary. This thickness reduces diffusion. So I said pneumonia, but it could also be pulmonary edema, ARDS, lots of different disease processes that increase the AC membrane thickness. Diffusion goes down in those cases. Okay, so if you're talking about diffusion, you're talking Fick's law. You can increase the partial pressure within the alveoli. That should increase diffusion. You can increase the surface area with PEEP. That should increase the diffusion. You may have an increase in thickness, and that will decrease the diffusion. Okay, so I just want to clarify that also. Now, the last thing I'm going to talk about here, which is a little bonus. Nobody actually asked this question, but I'm going to throw it up there because I think it's important. Okay, and these are when we talk about mechanical ventilation. Now, when we talk about mechanical ventilation, there's some things that you need to be reminded of and you need to remember as you prepare for your finals. So the first thing here are variables. There's variables within mechanical ventilation that you need to keep in mind and be aware of. Okay, so let's just talk about some of those variables. The first one is trigger. Remember, trigger is what begins inspiration. Okay? Trigger begins inspiration. It is the mechanism that tells the ventilator to give a breath. Or it's the mechanism that the vent recognizes is coming from the patient asking for a breath. So trigger is what tells the ventilator to either allow a spontaneous breath or to give a mechanical breath or to assist or synchronize with a patient's effort to breathe. Now, trigger comes down to this. If it's on the machine side, it's always time trigger. When you're talking about trigger on the patient side, it's one of two things. It's either pressure or it's flow. That's it. The patient will either create a negative drop in pressure, which will tell the vent, oh, we've lost pressure, the patient must be breathing, so let's allow them to breathe, either spontaneous, assisted, or synchronized. If it's flow, then they're going to take a portion of a bias flow out of the circuit, and the vent's going to go, wait a second, we're missing from our bias flow, which means the patient must have taken it. There's no other component to it. It's the vent and it's the patient. If the patient sucks and removes flow from the bias flow, then the vent says, I must give a breath. Assisted, synchronized, or true spontaneous. Whatever it might be. Okay? So don't forget trigger. That's the beginning. Now, and this is a big deal because the next one we got to talk about is cycle. Okay? Cycle ends inspiration. So your cycle mechanism is what tells the ventilator to stop giving the breath and allow exhalation to happen. Okay? If you're in volume control, this is volume. If you're in pressure control, this is I time. If you're in pressure support, this is flow decay based on the patient's inspiratory flow for that breath. So the patient takes a breath. As their lungs fill, the inspiratory flow slows down, and the ventilator says, oh, turn off inspiration and allow the patient to exhale. Those are cycles. Cycle is what ends inspiration. Now, these are two very important terms that can be easily conflicted, okay, easily confused. You'll hear reps and ventilator companies and reps for these companies talk about auto-cycling. Well, what is auto-cycling? I say, well, when the vent gives a breath when it really wasn't triggered by the patient. That's not auto-cycling, that's auto-triggering. Okay? So you have to understand, if the vent is giving breaths due to excessive condensation in the circuit, and it's auto-triggering, then it's giving breaths that really aren't being asked for by the patient. But that's an auto-trigger, not an auto-cycle. Okay? So have these terms really, really clear in your mindset. Okay? There's also limits, and these are things that cannot be exceeded. Y'all get what I'm saying there, right? Limits cannot be exceeded. So if you're in volume control, AC volume control, you have a set tidal volume of, say, 400. That volume will not be exceeded in any one breath. You also have a set flow. The flow will also not be exceeded in any one breath. So if you have a tidal volume of 400 and a flow of 60, then your max tidal volume delivered is going to be 400. Your max flow delivered is going to be 60 liters per minute. Your pressure will vary, and it can go as high as you allow it to, unless you have your alarm, especially if you don't have your alarm set appropriately. Okay? If you're in pressure control, then your I time is a limit, because the inspiratory phase will not exceed the set I time, and the inspiratory pressure will not exceed the set inspiratory pressure. But your volume is not a limit. Your volume can go as high as it wants. Okay? Now, we're talking about limits, and I'm going to leave it at that because that's a big topic here. The only other thing I want to talk about is when we talk about alarms. When we talk about our PIP alarm, our peak inspiratory pressure alarm, you need to understand that this is the only alarm that will also serve as a limit. So the peak inspiratory pressure alarm will terminate a breath if that pressure is reached. You have high tidal volume alarms, you have high minute ventilation alarms, you have high rate alarms, you have a bunch of alarms with high limits. But they just tell you if those values are being exceeded. If you get a high tidal volume alarm, then hey, patient's getting high tidal volumes, but they're still getting those high tidal volumes. If you're getting a high inspiratory pressure alarm, you're most likely in volume control ventilation, and you need to understand that that tidal volume is being terminated. So if you have a tidal volume of 400 and you're peaking out at your peak inspiratory pressure alarm, then you may only be delivering 300. Well, if you're only delivering 300 with every single breath, then the termination of that breath is ultimately going to affect minute ventilation. And if you ultimately affect minute ventilation, then you ultimately affect CO2 removal, which affects pH. So you want to be aware of that, okay? The last thing I want to talk about in mechanical ventilation is understand pressure versus volume ventilation. Remember, when you're in volume ventilation, you will set your volume and your pressure varies. Okay? When you're in pressure ventilation, you set pressure and volume varies. Okay? This is important to understand. This is the keystone of mechanical ventilation. Understanding that in volume ventilation, you set a volume and your pressure will vary. In pressure, you set a pressure and your volume will vary. Now this brings up another point here, okay? When you're in volume control ventilation, because pressures can vary, okay, you're not so much concerned about hyper or hypoventilation, specifically hypoventilation, because you're giving a set volume at a set rate. You're more concerned in volume ventilation with barotrauma. Pressures can get dangerously high, and you need to be aware of that. Okay? When you're talking pressure ventilation, you're not so concerned with barotrauma at this point. Not that it's not important, but you're not going to have this varying pressure that can creep up, and keep going higher and higher and higher, right? What you're more concerned with is changes in changes in tidal volumes based off of lung compliance and airway resistance can result in increasing or decreasing volumes, which can increase or decrease your minute ventilation, which can increase or decrease your CO2 and cause variances in your pH. And you also need to be concerned with volume trauma. This is where you're not so much worried about high pressures, you're worried about excessive volumes. Okay? In volume ventilation, you set a volume, pressure varies, you're worried about barotrauma. Understand that changes in compliance, a decrease in compliance will increase your peak inspiratory pressure. An increase in airway resistance will increase your peak airway pressure. Okay? And the exact opposite is true in pressure control. If you're in pressure control, a decrease in compliance will decrease your volume delivered. An increase in airway resistance will decrease volume delivered, and vice versa. Okay? Hey guys, I'm about maxed out here at about 20 minutes. Best wishes to every single one of you as you prepare for your finals. I would love for 50 comments to come back at the end of this week and say, yo dude, I killed it. Whether it was from one of these videos or just you studied your ass off, whatever, I killed my finals. Do me a favor this week when you get done with your finals. Give me an update. Say, dude, I killed them. I am on my way to being a respiratory therapist. I'm learning what I need to learn. I'm demonstrating that knowledge through my exams and through my competencies, and I'm excited. Okay, you got a break coming up, guys. Finish strong.